Very good morning to you, ladies and gentlemen. So we kick off today's proceedings with the first plenary session, which is delivered by Professor George Dalekos on autoimmune liver disease, what the internist should know. To start off proceedings, could I please invite Dr. Upul Dissanayake, the immediate past president of the Ceylon College of Physicians, and Professor Arosha Dissanayake, professor in medicine, Faculty of Medicine, Ruhuna. Thank you. Over to you, sir.
Right, a very good morning to all of you, ladies and gentlemen. I'm Arosha Dissanayake, Dr. Upul Dissanayake. It is our pleasure to chair this plenary. May we invite Professor George Dalekos to the podium. Professor George Dalekos, MD, PhD, FEFIM, FAASLD, is the current president of the European Federation of Internal Medicine and head of the Department of Medicine at Larissa University Hospital, Greece. He will be speaking to us on autoimmune liver diseases, what the internist should know. Over to you, sir.
Thank you very much, Mr. President, for the kind introduction. First of all, I would like to thank the CCP and particularly the President, Professor Prasad Katulanda, for the kind and honorable invitation to be here in this amazing country and city. These are my conflicts of interest for this specific lecture. And as we are, first of all, clinicians, I used to start my talks with representative cases that my group faces in our everyday clinical practice. And I will come back to these cases at the end of my talk later on. So the first case is a 52 years asymptomatic male patient with a long past history of transaminasemia, as you can see here in the left part of the slide, but now near normal during our evaluation for the first time from my group. With steadily normal bilirubin, no history of alcohol, drugs, herbal supplements over the counter, and the testing for viral hepatitis B and C was negative. And as you know, of note, ferritin levels were quite high, but again, now during our first evaluation, ferritin was normal. There were two working diagnoses in two European centers in Turkey and Germany. The first was MAS, metabolic dysfunction-associated steatohepatitis, with high ferritin levels, but without liver biopsy, which is a prerequisite for the diagnosis of MAS. And the second working diagnosis was hereditary hemochromatosis, even though the genetic testing was negative. During first evaluation from my group, the patient unfortunately has established cirrhosis as attested by transient elastography by FibroScan, as you can see in the slide. And we'll see later on what happened with this patient. The second case was a 53 years completely asymptomatic female patient with clustering of autoimmunity for several years. As you can see, the patient suffered from Raynaud's syndrome, Hashimoto thyroiditis, dry mouth, or Zika syndrome, and mild elevation of IgM immunoglobulin. The liver functional test referred as normal during the last 10, 15, 20 years in the annual checkup, but we noted that there was no determination of alkaline phosphatase ever. 3 years ago, the patient, even though was asymptomatic during her annual checkup, as you can see in the left part of the slide, has an increase of LFTs and particularly of the cholestatic enzymes gamma-GT and alkaline phosphatase, and a superficial investigation by her physician by ultrasound was negative. When came to our department, the patient was still completely asymptomatic with obvious cholestatic profile of liver enzymes, viral hepatitis markers, ultrasound were normal, and there was no history of alcohol, drugs, and supplements. Autoimmune liver disease, mainly autoimmune hepatitis, primary biliary cholangitis, and primary sclerosing cholangitis are very heterogeneous diseases, and some patients have manifestation from both autoimmune hepatitis and PBC, or autoimmune hepatitis and PSC. These are the variants of the diseases that I cannot speak about today. Here is the outline of my talk. Because of the time frame, I will discuss only autoimmune hepatitis and PBC. Regarding autoimmune hepatitis, this peculiar disease is a highly heterogeneous, immune-mediated, acute, or more frequently chronic hepatitis of uncertain cause, characterized by diffuse polyclonal hypergammaglobulinemia with a distinct increase of IgG immunoglobulin in most cases, the presence of circulating autoantibodies, usually the absence of other liver diseases, the presence of portal or lobular hepatitis on liver biopsy, and a favorable response to immunosuppression. Unfortunately, the disease has a very negative prognosis with high mortality, as you can see in the slide, if the disease left undiagnosed and untreated. Unfortunately, there are many preconceptions regarding this disease, like autoimmune hepatitis is a very rare disease, or is a disease exclusively of young children and young females, and I'm here to tackle all these options. There is no doubt that autoimmune hepatitis is on the rise during the last decades, and both the incidence and prevalence of the disease are very high, higher than the previous years, and you can see in the slide from representative studies from UK, New Zealand, and Denmark. Unfortunately, there is no characteristic clinical sign or symptom or any laboratory finding for this disease. And the disease can affect everybody, irrespective of age, sex, religion, race, and ethnicity. And as you can see in the slide, most of the patients are completely asymptomatic or with an insidious onset with general symptoms like malaise, fatigue, chronic pain in the right upper quadrant, weight loss, etc. This is why the diagnosis of the disease is usually delayed, and this can explain why at first evaluation 20 to 40% of the patients have already established cirrhosis. And here you can see that the laboratory findings are, like transaminases and bilirubin can be just above the upper limit of normal up to very high levels. And of course, the most characteristic is the increase of IgG immunoglobulin, but not in all cases. And this, as I already told you, can result in catastrophic consequences for the patients. As you can see here from our first results from the Greek autoimmune hepatitis database, you see that the mean delay of the diagnosis is above of 2 years. And this is associated with the presence of cirrhosis at first evaluation. And we know that the prognosis of the patient is negatively affected if there is cirrhosis at first evaluation, as you can see here from an old study from Canada. So for the clinician, for the internist, for the GP, it's very important, it's very challenging to can recognize this potentially catastrophic disease, because there are many diagnostic dilemmas and challenges as the disease remains an art for the clinician, because any increase of liver enzymes, particularly of AST or ALT, could be due to autoimmune hepatitis, because there is no single test to diagnose or exclude autoimmune hepatitis, like, for instance, the presence of hepatitis B surface antigen for the diagnosis of hepatitis B virus infection. So, according to the guidelines, autoimmune hepatitis should be suspected in all patients with elevated aminotransferases of unknown etiology, irrespective of the level of the increase, especially in the presence of elevated IgG levels and circulating autoantibodies. But don't forget that normal IgG levels cannot exclude the diagnosis of autoimmune hepatitis. The diagnosis is established according to a simplified score published several years ago in 2008 in hepatology, which is based in only 4 parameters: the presence of autoantibodies, the presence of high IgG immunoglobulin levels, the presence of hepatitis on liver biopsy, which is a prerequisite for the diagnosis, and the absence of hepatitis B and C virus for the chronic cases, and in addition, the absence of hepatitis A and hepatitis E viruses for the acute cases. Please don't forget hepatitis E virus when you differentiate a patient with increased transaminases. But there are many asterisks to these simplified criteria, and some small letters, like the small letters of the bank loans, So you should be very careful. And the first asterisk is what you see in the slide, which is the algorithm for the proposed autoimmune serology investigation for an index patient, because the autoantibodies are detected in more than 95% of the patients if testing strictly adheres to the guidelines. And this first screening should be done by indirect immunofluorescence on fresh frozen liver, kidney, stomach, rat substrates, in parallel with the investigation for anti-SLA-LP autoantibodies. And this is very important. It's very important for the patient, but also for you. And therefore, the guidelines emphasize that the routine clinical laboratory should comply with the guidelines, both regarding the cutoffs of reporting, but also for the techniques they use during this investigation. So you should discuss with the laboratory personnel if the investigation has been done according to the guidelines. Otherwise, you have detection of autoantibodies or no detection outside the guidelines, which can result in an exacerbation of misdiagnosis of the disease or an exacerbation of seronegative autoimmune hepatitis cases. The second asterisk is the liver biopsy. As I told you many times, liver biopsy is a prerequisite for the diagnosis, and it is preferable and ideal the interpretation of liver histology to be done by a specialist liver pathologist and not a general pathologist in order to be able to record the portal or lobular hepatitis according to the recent consensus on the histological criteria by the International Autoimmune Hepatitis Pathology Group. The third asterisk is a nightmare for the clinicians. As you can see here in the slide, is a suggested algorithm for the differential diagnosis between pure autoimmune hepatitis and cases with a very enigmatic and problematic entity named drug-induced autoimmune-like hepatitis, which means that we have some features of autoimmune hepatitis, but it's not definite. Autoimmune hepatitis is like autoimmune hepatitis because of any drug, herbal, or supplements consumption of the index patient. And this is the suggested algorithm where in practice you can start corticosteroids and then you should tapering very rapidly and stop corticosteroids in 1 to 2 months. And if the transaminases increase again, there is a relapse. This is definite autoimmune hepatitis, otherwise this is drug-induced autoimmune-like hepatitis. So there are many asterisks, and you should discuss with your laboratory personnel and also with your pathologists. The second autoimmune liver disease that I will discuss today is primary biliary cholangitis, previously named as primary biliary cirrhosis up to 2015. And this disease is a chronic autoimmune cholestatic disease, mainly of middle-aged women with characteristic autoantibodies and progressive destruction of small intrahepatic bile ducts that may lead to end-stage liver disease. As you see here, there is an increase, also as in autoimmune hepatitis, there is an increase in incidence and prevalence, and this is a worldwide phenomenon because of the awareness of the physicians and also the better laboratory testing. Of course, there is a predominance of female patients, as you see in the slide, but very interestingly, there is increasing diagnosis in males. Don't forget males with cholestatic syndromes. Almost half of the patients are completely asymptomatic during the diagnosis, and as in autoimmune hepatitis, there are also median delay for definite diagnosis. Contrary to autoimmune hepatitis, this disease does not affect children, and this is a very important difference between the two diseases. As I told you, the vast majority of the patients are asymptomatic at diagnosis. The major symptoms could be pruritus, generalized pruritus, and fatigue. As in autoimmune hepatitis, we have many concurrent extrahepatic autoimmune disease with Zika or Sjögren's syndrome, Hashimoto's thyroiditis, and Raynaud's syndrome, the most important and the most common extrahepatic diseases in this autoimmune liver disease. The diagnostic algorithm in chronic cholestasis is quite simple. Contrary to autoimmune hepatitis, if you have a patient with cholestasis with increased gamma-GT and alkaline phosphatase and negative viral hepatitis markers, then you should take a thorough history for several drugs, supplements, etc., physical examination, and an abdominal ultrasound. If this ultrasound is negative, which means without focal lesions of the liver parenchyma and without dilated bile ducts, that the next investigation is about the PBC-specific autoantibodies, namely antimitochondrial autoantibodies and PBC specific anti-nuclear antibodies. If you have these two, the cholestatic profile and the autoantibodies, this is PBC. You can proceed to the diagnosis without performing liver biopsy, and this is another distinct difference with autoimmune hepatitis, and this is very important, very important. But as in autoimmune hepatitis, the investigation should be done according to the guidelines, and the first screening is also the indirect immunofluorescence on fresh frozen liver, kidney, stomach, rodent tissue section. And if this test is negative, then you should investigate for antimitochondrial antibodies by ELISAs, but these ELISAs should have the three major autoantigens of antimitochondrial antibodies, otherwise it's useless to investigate the patient. And it is, and of note, we know these three major autoantigens since 1987. And if also the ELISA test is negative, then you can proceed to the investigation by immunoblotting. So it's not so easy to say that a patient with cholestasis and normal ultrasound is negative for antimitochondrial antibodies. You should be very careful and sure that the negative is negative. The second type of autoantibodies that you should investigate, particularly if the antimitochondrial autoantibodies are negative, are specific, which means that these antinuclear antibodies are detected only in patients with primary biliary cholangitis, and these are, as you see in the left part of the slide, the RLM pattern is a peripheral pattern in the indirect immunofluorescence, and in the right part of the slide is the MND pattern, which means multiple nuclear dots pattern, and we know also the major autoantigens of these autoantibodies, and therefore we can proceed with ELISAs and immunoblotting. So you need to investigate thoroughly if you have a patient with cholestasis of unknown origin. So I hope that I convince you that the liver autoimmune serology testing in these diseases is very important, both for you, but also for the patients. And why is it important to suspect and diagnose primary biliary cholangitis? Because as you see in the slide, the disease runs a silent course, and our main target is to diagnose the disease as earlier we can in order to put the patient in treatment with ursodeoxycholic acid in an attempt to tackle the progression to end-stage liver disease. And because we know that in the absence of treatment, almost 40% of the patients can progress to end-stage liver disease with the development of cirrhosis in 4 to 10 years. So it is very important. Coming back to our clinical cases, the first case with the male patients with a long past history of transaminasemia. As you can see here, the liver autoimmune serology investigation in my lab was positive for autoantibodies, and of note the patient had also antithyroid antibodies, and this is an indication for subclinical Hashimoto thyroiditis. And remember that I told you that both diseases, autoimmune hepatitis and PBC, are associated with many extrahepatic autoimmune diseases, with Hashimoto thyroiditis being the first most common extrahepatic autoimmune disease. After all, we proceed to liver biopsy, which is a prerequisite, as I told you several times, today. And the diagnosis was autoimmune hepatitis-related cirrhosis because of undiagnosed and untreated autoimmune hepatitis, which means that this is the natural history for the disease. Unfortunate for this patient, and you see here the liver biopsy, which is not a surprise, of course, because I told you that almost 1/3 of the patients have already established cirrhosis, and this is not a very good prognostic sign for the long-term outcome. The second case with the 53 years lady who was completely asymptomatic with cholestatic syndrome, as you see here. Unfortunately, also this patient at first evaluation was already cirrhotic by transient elastography with using FibroScan, and also there was dilatation of the portal vein, which means that we have compensated cirrhosis with portal hypertension. And the autoimmune serology in my lab was very high for anti-mitochondrial antibodies and also anti-centromere antibodies because of the presence of Raynaud's syndrome. As you can see, the IgG levels were normal, but IgM immunoglobulin was very high. And even though IgM is not part of standard diagnostic algorithm, can be used and can be useful as a surrogate marker in making a clinical diagnosis. So the final diagnosis for this patient was PBC-related compensated cirrhosis, and also this was the natural history of the disease because the disease has started 22 years ago. But as we are internists, it's very important to emphasize that we should treat the patient, not the disease. Don't forget this. Don't forget, please, this. Because the patient has many problems. This index patient has dry mouth, dyslipidemia, Raynaud's syndrome, autoimmune thyroiditis, osteopenia because of the chronic cholestasis, and of course, impaired quality of life. And the internist and the general physician should deal with all of this, and this is internal medicine. So, Mr. President, in conclusion, autoimmune hepatitis should be considered in any patient with acute or chronic liver disease, irrespective of age, sex, and ethnicity, particularly in the context of high IgG immunoglobulin levels. Unfortunately, there is no single test to diagnose or exclude autoimmune hepatitis, but the presence of autoantibodies remains the cornerstone of its diagnosis if strict adherence to guidelines is applied. The liver biopsy, I told you several times, I hope that you understand this, is a prerequisite for autoimmune hepatitis diagnosis, and this diagnosis remains an art for the clinician, as prompt and timely diagnosis is of utmost importance because if left untreated, has dismal prognosis. Regarding PBC, again, this disease should be suspected even in asymptomatic patients with persistent cholestasis, normal ultrasonography, and negative viral hepatitis markers. The presence of the specific autoantibodies, anti-mitochondrial and PBC-specific anti-nuclear antibodies are the cornerstones for PBC diagnosis, and contrary to autoimmune hepatitis, liver biopsy is not indicated for the diagnosis in these cases. Early diagnosis of PBC is very important as timely treatment initiation can tackle in the majority of the patients the disease progression. Thank you very much. Studi. And don't forget our esteemed Congress in the next year in March in Vienna. Thank you very much.
Thank you, Professor Dalekos. May I invite my co-chairperson, Dr. Upul Dissanayake, to present you with the certificate of appreciation. Please, if you could come on.
And also, I would like to invite Vidya Jyoti, Professor Prashant Katulande, to award the letters of appreciation to our chairpersons.